It is a pleasure to talk to everyone.
I've just started the recording. Go ahead, Vikram. Thank you.
Yes, I got that. Thank you. So what we are going to talk about today is documentation and litigation in interventional pain practice. Some of you might not actually know me. Some of you might. What would make you think that I really qualify for lecturing on this topic? Number one thing is I've been practicing in United States for more than 25, 30 years, since 1990. So that would be one qualification. I have been familiar with the litigation situation in US. And as you might know, United States leads the world in a lot of different things. Some are good, some are bad, and some are plain ugly. It may not be a politically correct statement, but I like to say what is in my mind. The second thing that qualifies me about this is that in my 25 plus years of pain practice, I have never been sued even once. And that is not what too many people who practice pain in US can say. And I have been on the sidelines, of course. I've trained a lot of fellows, a lot of pain physicians, and I have lectured them on proper documentation as well as how to avoid litigation and how to deal with that if it does happen. So with that, let me get started. So when I started my career in US in 1990, at that time I was at Cook County Hospital in Chicago, one of the very well-known hospital in the world actually. They knew that I was an anesthesiologist from India. I was board certified in India. And when I joined them, my first rotation, they put me at Oak Forest Hospital, which is a long-term care facility. Everyone is in either a wheelchair or a wheel bed, and people can go around the whole hospital because it is a single-story hospital with ramps. And that is where I was placed in the pulmonary ICU. So this was in July of 1990. My attending in the ICU, pulmonary ICU, was Dr. Chin. First day, we meet in the morning and we go over the rounds. I basically updated him on the patient's conditions. I had 16 patients, everyone on ventilator, everyone either quadriplegic or just basically, in simple words, brain dead, chronic vegetative state. They all had some history, and they had been there for many, many years. Our longest staying patient there was more than 5 years at the same facility, intubated on a ventilator. And it is a very sad situation to see all these people. Unfortunately, no one could really stop the ventilation or pull the plug, so to say. And the reason for that was that required a court order to do that. And the legal system came into play. And people who did not have any next of kin were kept on ventilator for a very, very long time. So after we finish our rounds, Dr. Chin says, okay, just finish up the soap notes. And I look at him like an open mouth. I said, what? Soap note? And he says, yeah, soap note. I said, no, I have no idea what you mean. And he says, well, soap note actually is a short form for subjective, objective, assessment, and plan. And that is the way to document your daily report for a patient. In India, we used to call it ODP, origin, duration, and progress of the disease. So that is what is called SOAP note in US. And I said, okay, so what do you mean to want me to write down? And he says, just one thing to remember. Write your SOAP note as if it is going to the court tomorrow. So write things that are necessary. Don't write things that are not necessary. And don't put anything that you do not see. And always write something that you see. And you should be able to defend your note in the court tomorrow if it ends up in the court. And I think that was probably the best advice I ever got in my training in USA. Over time, I've learned some lessons, of course, and as you can see, my previous introductory picture, is not exactly the same as what I look right now. It's not always what you see is what you get. So what I learned over time was your experience does not really matter. When it goes to the court or even for anything else, your experience does not quite matter. Sometimes in front of the judge it might. And let me tell you a short story. I was called for a jury duty. In USA, it is required that every citizen provide some duty in a jury when required. And the jury duty for the whole day would pay you somewhere near $16 to $18 per that day. That is supposed to include your lunch and your dinner, not likely dinner, but lunch and your transport. In Chicago downtown, lunch itself will cost you $30. So actually you might end up losing money. But that is a civic duty that everyone has to perform as a citizen of the United States. So I'm there. I was chosen for possible jury duty. I'm sitting in the court and the judge has called people around. I was chosen to be one of the first 12 and the jury is made up of 12 people. And if you have seen that movie 12 Angry People or 12 Angry Men, that is what it looks like. During my introduction, the judge would come around and ask everyone, please introduce yourself and tell us if you can judge this case without any bias. When it came to me, I said, I'm sorry, but I will be biased. And the judge says, why? I said, because I'm a pain physician. And he said, okay, stop right there. Let's go to my chambers. Let's discuss that. So we entered the chamber and the judge says, what makes you think you will be biased? I said, because I know the plaintiffs who are complaining of hip pain do not have any hip pain. So how do you know? Well, because I've seen this kind of patients for more than 20 years in my lifetime. And I can tell if someone is particular gait just by looking at them if they have pain or not. And of course, none of the lawyers wanted me, and the judge also did not think I would be unbiased. So I was released to go home. But so in that case, my experience did matter for a short time. Your expertise also does not really matter. Who you are also does not matter. So whether I'm a medical director, I just came out of my residency yesterday, all this does not really matter. What really matters is definitely your documentation. When you see a patient and when you document your chart for the same patient on the same day, that is what matters on what you did for the patient and why you did it. So did you do it or did you not do it? That is the question, right? And one wants to document only what you did. For example, I'll go into that a little bit more detail later on. With the new systems of EMR, electronic medical records, it is so easy to document something in the chart that never took place. For example, someone comes to you for back pain and you document HEENT, cardiac, pulmonary, abdominal, all these exams, integumentary, and then finally when it comes to the lumbar spine, your documentation is blank because by that time you reached a point where you can build to a certain level. So people sometimes miss that. And you did not really listen to the patient's bowel sounds, but your pre-populated document chart would say bowel sounds normal, no organomegaly, no tenderness. And if it goes to the court, the lawyer would first ask the patient, this doctor says that he heard bowel sounds in your abdomen. Did he actually put a stethoscope on your tummy? And the patient says no. Immediately the jury will have a doubt. And the lawyer would probably say, this doctor is in the habit of writing things that he never does. So if he gave this treatment to the patient, how do we actually know that he did it? Because he has a habit of documenting what he never does. Then there are some standard of care, guidelines, and evidence-based practice that matters. Standard of care is actually seen as a legal requirement. So if you are, for example, putting a patient under sedation, and if you do not monitor pulse oximeter or respiration, then it is a breach of standard of care, and it is basically just malpractice. That is not supposed to happen. Guidelines are just guidelines. They can be leading you to a particular treatment plan, but they are not absolutely followed. Evidence-based practice means something that you have the evidence for in the literature that you apply to the patient's disease and give the treatment. So proper documentation, why is it actually important? There are, of course, clinical ramifications, mainly because you want to document what the patient has. What is your diagnosis? What is the differential diagnosis? And as we all know, diagnosis is not just based on a single symptom or single sign. It has to be multiplication of signs and symptoms, imaging studies, or any other test like blood test or whatever. And that all leads to a possible diagnosis. And in pain, actually, we do some diagnostic injections to be almost certain that the pain might be coming from that area. And that is the clinical ramifications of proper documentation. You want to be able to treat the patient for what is going on and avoid the treatments that would not be beneficial to the patient. It is important for ethical medical practice, of course, and patient care. It is important to establish proper diagnosis, treatment plan, all that is based on evidence-based medicine. And sometimes people would say, some of my friends actually say, my evidence is what my patient tells me. If my patient gets better, that's the evidence-based medicine. No, it is not. Evidence-based medicine is based on published documentation. In peer-reviewed journals, a publication has several levels of authenticity, and the most reliable one is supposed to be evidence-based guidelines published by several different societies or even certain physician groups, and that is the highest level of evidence. Then you have evidence based on separate studies that are placebo-controlled double-blind studies, for example, randomized controlled trials. Then you have evidence of case series or case reports, and then the consensus committee statements come almost at the last. It is, if you look at it like a pyramid, at the top is the evidence-based medicine guidelines. So if you follow those guidelines, at least you have some standing in why you applied certain treatment to a certain patient. Ultimately, it provides the patient with satisfaction with their treatment and diagnosis. You can retain the patient for longer time, and your outcomes would be optimal. Another reason why is it important? For business ramifications. And medical practice, especially in US, and now it has been in the rest of the world as well, it has turned into a business. And the reason is because the way it is run, the medical practice is run, is almost similar to running a business. You have a supply and demand for a business, just the same as we have it in medicine. Patient comes to you demanding certain things, and you provide what the patient needs. The medical staff office has to know what you're doing. If you just tell them, a patient has some facet joint pain, book them for some facet injections, that staff would not be clear on exactly what is to be scheduled. Are you going to schedule the patient for medial branch block? Are you going to schedule the patient for radiofrequency, intra-articular steroid? No one knows. Are you going to do it under fluoroscopic guidance, under CT guidance, under ultrasound guidance? They don't know that. So with proper documentation, if you are planning to do a medial branch block at L5S1 level, which would be L4 and L5 nerve roots, medial branches, then you actually want to document it as such. L5S1 facet joint medial branch block with medial branches L4, L5 under fluoroscopic guidance with local anesthetic only. That is proper documentation. If you just say facet injection, that means literally nothing. It will also help getting timely authorizations, which of course helps the patient get proper treatment in timely manner. Billing and coding is all dependent on your documentation. If you say you did something, but you actually did not do it, then you may not get paid. or if you are authorized to do something and you do something else. If your authorization says you can do appendectomy because the patient has acute appendicitis and you end up taking the gallbladder out, then you may not even get paid. So getting paid for what you do is very important.
I think, Vikram, it's on the whiteboard. Somebody's written. I'm trying to get rid of it, but I think you'll probably.
Yeah, I think.
Continue. No worries. I think
not
discussed. You can continue. You can carry on. Thank you.
Okay, thank you. Then what is more important, what we are going to discuss today is the legal ramifications of your documentation. It is important because it's a possible defense in case of an adverse event and subsequent lawsuit. And unfortunately, United States leads the world in lawsuits against doctors, against everyone else. In US, if something bad happens, someone has done it and someone has to pay for it. It's just not me. If I fall down in a store and I slipped on a grape that had fallen down, the store is liable for that. It's not me who did not see the grape on the floor and slipped on it. So that is how things are designed in USA. It may not be always true, and these are, of course, my opinions, but that has been happening all over the country all the time. I had read about some lawsuits in Reader's Digest a long time back. One of them was a person riding a bicycle in New York somewhere was hit by a Jeep at night. So he ended up suing the Jeep company and the bicycle company, as well as the driver who was driving the Jeep. And the reasons were, well, the bicycle did not say you cannot ride at night, okay? The Jeep did not have powerful enough lights that he could not see the person on the bicycle. And the driver, of course, was at fault because he did not apply the brakes on time. And then everyone probably heard about that McDonald's lawsuit when a woman was burned on her thighs because she held this cup of hot coffee between her legs and drove away, and the coffee spilled and she got burns. And it did not say on the cup that the contents are hot. Anyone with common sense would know that you bought coffee. It does not mean that you bought cold coffee or iced coffee. It is coffee that is hot. But that common thing made her file a lawsuit, and she won. And after that, you will see that on almost every cup that is sold in US at least, you will see the contents are hot label. Does everyone read that? Maybe, maybe not. Just like the cigarette carton. Everyone reads that, okay, it is injurious to your health. Do they stop smoking? Hardly. Same thing, recently I read that FDA is going to have a new requirement to stamp all the opioids with injurious to your health and some warning label that says it might lead you to suicide or whatever, and overdose deaths, which have increased recently quite a bit, especially with synthetic fentanyl coming across the board from Mexico. That would not really prevent people from using opioids. They will not just look at it and say, okay, well, this one says it might make me commit suicide and cause overdose. Are they going to stop using that? I don't think so. But because it legally protects the seller of that medication, it has to be there. Continuity of care from one provider to the next without missing important medical data is very important. One time in the past, I read that a physician had documented myelopathy on MRI in a patient. And then he says, well, the patient doesn't have myelopathy, but your signature is on that chart that says patient does have that. So if it goes to the court, if the patient has adverse event and it goes to the court, there is no defense because you signed that document that said patient had myelopathy. If you say later on it did not, then you better add some addendum to it, or you get a new MRI to prove that there is no myelopathy. So that is the importance of continuing care for the patient. Another thing you want to do is mention everything the patient has and avoid mentioning what the patient does not have. If you give a patient wrong diagnosis, that sticks with the patient for the rest of their life. A lot of times I've seen physicians giving patient diagnosis of fibromyalgia. They don't even know how to diagnose fibromyalgia, and they label the patient with fibromyalgia. Now the patient is psychologically stamped with the fibromyalgia, and everywhere they go, well, I don't think I can do this, I have fibromyalgia. Okay, well, patient may not even have that. They might just have simple myofascial pain, which might have gone away in a few days. No one knows. No one can predict the future. But now you labeled the patient with the wrong diagnosis. It also helps with, of course, your diagnosis and treatment plan. And then in USA, at least, this is what it is called. Knowingly falsifying medical records is a felony crime. It has potential for fine of up to $250,000 or 5 years in prison. And that is basically extrapolated as falsifying medical records for financial gain. So if you want to do a, let us say, a vertebroplasty, and you say the patient has vertebral fracture, and the patient actually does not have that, but you wanted to do vertebroplasty because you just learned that over the last course that you went over the weekend, and now your hands are itching to do this vertebroplasty. Let me find a patient to do it because it's going to pay me. And believe me or not, when everyone goes to medical school, the morals are very high. I'm going to come out and cure the rest of the world for the medicine, for the diseases, and I'm going to be the cure of everything the patient suffers from. When you come out of pain fellowship, for example, you feel like I can treat each and every pain that exists under the sun. Good luck with that. It doesn't happen. So just to perform a procedure, if you falsify the documentation by giving the patient wrong diagnosis, the only person that is going to get paid is you, not the patient. Patient gets treated, yes, but payment comes directly to you, so that is financial gain. And for that financial gain, if you falsify something and give the patient a wrong diagnosis or document something wrong, then it is a felony. So never document what you did not do, and always document what you did. So in anesthesiology, we were supposed to, this started when I was late in my training at that time, mid to late 90s. Antibiotics intraoperatively for all the surgical procedures. Sometimes people would forget, but they would still go ahead and write down in the chart, patient got 1 gram of cefazolin, and patient not have received that. But if it is in the chart, you gave it. If it's not in the chart, you did not. I even had one of my colleagues actually who used to use opiates for himself, and he would steal it from patient supply, and he would inject it himself, and he would say it went into the patient. Now, if the patient has a complaint against it, and if they get blood test for any metabolites, and if they don't come out, then of course he will be in trouble. But that would hardly even happen. So that is something that is to be remembered, that if you do not do something, never document that. And if you did something, always document it. Always avoid documenting what you find is something you never want to do, regardless of the consequences. If you were doing a cervical epidural steroid injection and the patient immediately starts complaining of some numbness in the arm, you want to document that. You want to document AP and lateral views. It is possible you are touching the spinal cord. It is possible you are touching the nerve root without even knowing it. But if you hide that and the patient decides to go for litigation afterwards, in that case, there is hardly any defense. If you say, sorry, I did not document anything that happened, and I did not have any means to document the fluoroscopic pictures because I had an old C-arm that did not store any images. It had hard drive that was small, it was full. That is not an excuse that anyone would like to listen to. So if you have something, admitting your mistake is a lesser crime than avoiding admitting the mistake. Be specific with your documents and the relevant data, and that will go a little bit in detail later on. Who requires your documentation? Of course, your patient does, because they want to know, or they're entitled to know, what is going on with their bodies and what kind of treatment is given to them for what purpose. Your referring doctors need to know what is going on with the patient. If you give a patient certain type of procedure or treatment, the referring doctor has to know what the patient had. For example, if you inject steroid, and if you don't tell the referring physician you already gave the steroid to the patient might get additional steroid injections for, let's say, shoulder injection, knee injection, hip injection, or even foot injection. And that amount of steroid will add up over time. And not too many people would know about it because you did not tell anyone. The lawyers, of course, always would want to know exactly what you documented, and especially the plaintiff's lawyers. People who complain, their lawyers have a legal requirement to obtain all your documents. And they can go back to see your pattern of treatments, and they can call your witnesses that have been treated in the past by you and may not even be happy with your treatments. Your malpractice carrier requires to know that what you did and how you did and what happened. Long time back when I was in my fellowship, and this is an important story for everyone to understand how important documentation is. I was in my fellowship training. We had a patient with post-laminectomy syndrome, radicular pain. We evaluated him, sent him some for physical therapy in aquatics, started him some NSAID, some anti-inflammatory medications along with some antidepressants. Pain is still the same, so we went ahead and did a caudal epidural, and I was the one who did the caudal epidural. At that time, it was not required that the attending sign all the notes for the fellows. So I signed the notes, and we did the epidural injection. Patient got better, came back for a follow-up after 2 weeks, and I asked him, so how is your pain? Oh, the pain is much, much better. I was able to do a lot of stuff. He said, well, what did you do? Well, I actually carried my mattress from my first floor to the second floor just by myself. I feel great. So I documented that. Patient was able to carry the mattress from the first to the second floor. And first floor in USA is the ground floor, which is in a lot of other countries. So he was able to carry the mattress by himself up one floor. About 3-4 months later, the patient files a lawsuit against the whole hospital. That's called a blanket lawsuit. Everyone who was involved in treating that patient got involved in the lawsuit. The neurosurgeons, the physical therapists, the pain department, everyone was named. So I was called to this legal department and said, this patient has complained against you as the treating physician, but we see that you are actually a fellow. So your attending should be the one who is named in this, not you. So we'll take your name out. They took my name out from that. So I was not in that lawsuit. Later on, they actually sent me a thank you letter. And my one sentence that said patient was able to carry the mattress from the first to the second floor, just one sentence, got the whole hospital out of that lawsuit. Because anyone who can perform that activity cannot be disabled, cannot be in that much pain, because you carried the whole mattress up to one floor. So just that one sentence saved a huge lawsuit against the hospital, the spine surgeons, the pain clinic, and everyone else involved. So that is the importance of letting the malpractice carrier know. In my case, it was a self-insured hospital. So the hospital carries its own insurance, and it saved them from a bunch of money. The insurance companies or health plan want to know what you document, why you want to do certain procedure. And for yourself, you want to know. If you had done something last month and you have seen about 500 patients since then, it is not likely that you will remember exactly what patient got what treatment and what kind of problem they have. It is very important for you to remember whether you treated the right side or the left side. I had a patient one time who came back and said, well, doctor, that treatment you gave me about 2 months ago, not working anymore. Okay, well, that's possible, but let me see what we did. We had done radio frequency on the left side. And I said, so is that your left side hurting? no, the left side is fine. It's my right side that is hurting. And I said, well, you never had pain on the right side before that you complained to. I said, no, I always had right-sided pain. I said, okay, let's open your patient diagram. And when my patients came in as new patients, they used to fill out this patient pain diagram, which I think almost everyone should do and are doing already. And the patient had marked everything on the left side. I said, this is the diagram that you actually draw yourself. And that is why we are focusing on the left side pain, because your left side pain was probably worse than the right side. You complain only of the left side. And now you are realizing that left side is better, the right side is causing pain. So that is why you are having pain on the right side. And then that is why when you understood that the right side actually was not treated before. Excuse me. And it was the left side that was treated with radio frequency, and that pain was already gone. If you look at the amount of litigations in pain practice, as you see the graphic on the right side here, you can see appropriate MD management only about 14%, other issues about 18%, patient did not cooperate only about 24%. And that would happen like if you start a patient on antibiotics after an invasive procedure such as spinal cord stimulator, and patient does not take the antibiotics properly and gets infected, the stimulator comes out, and then they decide to sue you for infection. That does happen, but if you have documented, and I can give you the example, one of my last patients with spinal cord stimulator that I placed, nice guy, goes home after the implant, permanent implant. I gave his wife a big roll of tape. I said, if you see the dressing coming off before you see me in the clinic in 2 days, start applying this tape on it. No one removes the dressing. Unfortunately, when he came after 2 days, the dressing was off. There was nothing over the sides at all. I said, what happened? Your dressing is gone. Well, I sweat a lot, so the dressing came off and my wife did not want to put more tape on me. Okay. I said, if this guy's infected, it will be your fault. Are you taking the antibiotics I prescribed? Oh yeah, I take all 3 of them every day. I take them 3 times. I said, okay. Just while he was in the clinic, the pharmacy calls. I said, doctor, you prescribed this antibiotic about 2 days ago. Do you still want me to refill that? So what are you talking about? Well, the patient's daughter is here to refill this prescription that you gave 2 days ago. So I asked him, I said, you told me you're taking it 3 days a week, 3 tablets a day, and you are not taking anything right now because it's not even filled. Oh yeah, no, that is the medicine you gave me before. So that was actually gabapentin I had him on. I said, you are taking that medicine for a different reason. This is antibiotics I gave you. I told you to refill it right after you went home from the ambulatory surgery center. And, oh, doctor, don't worry about it. You did great and I never get infected. I said, okay, start taking them right away. He comes back 2 days later. Again, the dressing is gone. I said, now what happened? Well, I was not having much pain, so I was playing with my grandson and he had this water all over me and the dressing came off. I said, okay. So now what do we do? I document all that, and the patient had dressing off, did not notify me. And I said, now if this gets infected, you will be liable for that, not me. And we'll have to take this whole thing out that costs so much more money, almost equal to a Cadillac. I said, if I had given you a free Cadillac, you would have been brushing it and polishing it every day. Take care of this stimulator because it's a very costly procedure. And ultimately, it healed okay without any infection, and there was nothing more to it. But if he had gotten infected and if I had taken it out, he could have sued me for possible infection because of my post-op management. But my documentation would have definitely helped at that point. Unfortunately, that did not happen. Patient was fine. But those are the things that you want to document if the patient is not very compliant. And if you see majority of that, about 48%, inappropriate medical management, as well as patient did not cooperate. So patient's non-compliance, along with your medical management, if you combine both of them, if the patient shows some sign of infection, I had one patient my very first stimulator in 1994 that got infected. And I found out at that time we had these stimulators with the receivers under the skin and the transmitters outside the skin. And there was a dual-sided sticky tape that you would put on it, and the power source was outside. And they would be using the sticky tape to stick the transmitter antenna over the receiver under the skin. She ran out of those dual sticky tapes. So her husband, who was a carpet layer, had this dual-sided carpet tape that was, of course, not very sterile. So he put it on it, and she started using it again. Everything is working fine. Post-laminectomy syndrome, bilateral radicular pain. Then, because of getting old, the tape does not stick anymore. So husband just rips it apart, and that took the whole incision apart. It was not too old anyway. Then he said, oh, no big deal. He puts the two layers of the skin together, two edges, puts another tape on it, and puts another, and the wife is using the same thing again. Then they do it for a couple of weeks. By that time, this dirty, sticky tape, carpet tape, gets all the bacteria in the wound. She starts getting a lot of pus in there. The pus is pouring out. And that honestly was the first time I had seen pus in this country. I had not seen that in my residency anywhere. And one of the worst places I already worked at before. Never saw any pus coming out of any patient. And this patient has frank pus pouring out of that incision site at the pocket. And I asked her, I said, what happened? And she tells me the whole story. And we had to take out or explant the whole stimulator. And we had to wait for about 7 to 8 weeks before everything cleared. And then we had to put it again with a pocket on the other side. So those are the things, complications that can happen. Fortunately, with all the documentation, it would not have been upon us to prove that patient had done something wrong. Most of these opiate abuses come down to the doctor who has prescribed it. So misuse, overdose, diversion, and the diversion is a new term that has been used in USA at least. And when a patient is given a medication that they don't use properly, or they sell it, for example, then it is labeled as diversion or drug diversion. More politically correct term, in my opinion. Most common lawsuits secondary to death in young men with back pain, about 57% of all claims. And these were the overdoses with people getting opiates for just back pain without any proper medication management, monitoring, or without any proper other interventional treatments applied. They keep going on the opiates, they escalate the doses. Finally, they end up with an overdose. And these are mostly young men who are taking all these medications. They always show some red flags. For example, depression, suicide attempts in the past, other substance abuse. All these are red flags. And these patients getting opioids are more likely to undergo with an overdose death than anyone else. There is also a failure to monitor. And now almost everyone is required to monitor the patient for opioid intake. Inappropriate management and uncooperative patient, there is maximum of that with both of them in conjunction. So without monitoring the patient properly, without keeping track of their medications, if they are taking it properly or not, are they selling the drug, and if they are cooperative with your medications and only taking what you give and not doctor shopping, getting you the same prescription from 4 other doctors, all that can lead to overdosage and even death. Complications during and after interventional procedure is very, very likely. I can tell you about my tenure as an examiner for FIP exam. One of my first candidates that I examined, along with Dr. Gabor Rags, who most of you might know and should know, we are both examining him. It was done in Budapest, where the examination hall was not air conditioned at that time. So we had the windows open, it was raining outside, very humid, everyone is sweating, and especially the examinees who are already under tension and stress, they are sweating. They have already have their paper gown on and the lead gown also. So the first procedure was interlaminar cervical epidural. So sometimes when you're seen enough, you know that someone has already punctured the ligamentum flavum, and you can see them having that movement when they are advancing. So I saw that he was already beyond that. He keeps going a little bit. I knew he was probably a little bit deeper. And then one of the questions we asked during the exam is that your final position? And without taking an AP or lateral view, you cannot say it is your final position, because you can literally lay the needle on a patient's back and it might look like you're done an midline epidural injection. Unless you take a lateral view, then you can see it is not even anywhere close to the spine. So I said, would you like to take a lateral view? And he started sweating even more. Oh, sorry, I forgot. Took a lateral view. He's already deep enough. I said, now are you satisfied with your position? He thought he was not deep enough. He keeps going. Now he's in the spinal cord. He still keeps going till the vertebral body stops him. Then he cannot go any further. So it is an epidural injection, but he's in the anterior epidural space through and through the spinal cord. And that is not something uncommon that I have seen. It happens in a lot of cases. A lot of doctors who say they have practiced pain for at least 2 years before taking the exam have had that happen with them. So that is something that can happen if you are not vigilant with your treatment plan, with your technique. There was an interventional radiology case that I remember. It did not even go to litigation, probably more likely settled out of the court. So there is an obese patient getting cervical epidural injection, and the patient has sedation, about 6 milligrams of midazolam with an IV. The doctor does the procedure, does not use the contrast to confirm where he is because the contrast is very costly. He was apparently in the CSF, injects 5 ml of bupivacaine along with steroid. And all of that medication goes in the brain, of course, and puts the patient under general anesthesia. So now, when they finish the procedure, he is trying to wake up the patient, and of course, the patient does not wake up. Patient had already stopped breathing long time back. So now the problem was how to resuscitate the patient. No one in the room in this remote center where they were doing a procedure was ACLS certified. So even if they had the resuscitative equipment, they could not have intubated the patient in time. And that was a breach of standard of care. When you sedate someone, you monitor them for their oxygen saturation and their respiration and heart rate. That was not done. And using the contrast is not really standard of care, but it is guidelines. So he did not follow proper guidelines to assure that he was not in the intrathecal space, but in the epidural space. So there were 2 reasons why this patient literally died because of these mistakes. If there is a complication, if you fail to recognize, that is a problem. If you fail to treat, that's even also a problem. Complications during medical procedures are not unknown. A human dealing with a human body is not always perfect. Even the computers can never be perfect. The problem is, if you don't recognize the complication and if you don't treat it, that is a bigger problem. There is no defense for that. If you look at some definitions of complication, what is a complication? It is a pathological process or event occurring during a disease that is not an essential part of the disease. Something that is away from that might have been caused by the treatments applied. It may result from disease or from some other independent causes. And if you look at the word iatrogenic, what does that mean? It is induced by a patient by a physician's activity, manner, or therapy. By activity, it can mean examination. For example, I can give you another example of a patient who was referred to me for spinal cord stimulation back in 1994. And not too many people were doing it at that time. He was sent to me by one of my colleagues, who used to practice pain at a different hospital, but did not do stimulation. So I see the patient, he has post-laminectomy or post-discectomy. I tell him to flex forward. I said, how far can you go? And he goes about 10 degrees and starts shouting and yelling, oh, that is a lot of pain, lot of pain. Okay, we can stop. I said, where was the pain? Oh, it went all the way down to my leg. And I said, okay, well, that doesn't sound quite right, but tell me how exactly it followed the path. So at least, and at that time I was a fellow and I was trying to pinpoint which nerve root was causing the pain. And I said, well, unless you tell me the pattern of this pain radiation, I won't know which nerve root is causing your pain. So why don't you point it out to me, how it traveled? And then he goes all the way down, pointing to the foot. I said, okay, now you are able to bend all the way down. And he says, doctor, because you made me do it. Now that I had caught him, that he was not actually having this pain and he was faking it, there is no way he was going to sue me for that. But a patient can definitely come back and say, well, you made me do this during your exam and that increased my pain, so I'm going to sue you for increasing my pain. And that is something that can happen even during the evaluation. Forget about the treatment or anything else. Some of you might have heard about Murphy's Law. What is Murphy's Law? If anything can go wrong, it will. And so in long time back, Captain Edward Murphy was showing in a project by Air Force that a sudden deceleration, a person can stand in a crash, and they were evaluating that. And so there was a faulty transducer that was wired wrong. So he cursed the technician and said, if there is any way to do something wrong, he will always find it. The technician maybe always found something to do in a wrong way. And so the contractor's project manager, who used to keep a list of these such laws, he added this to one and called it a Murphy's Law, that if anything can go wrong, it will. So always be prepared for that if you can. Some of the common examples of complications from our interventions. They can be anything from good or bad or ugly. Transient blindness is known to happen after any epidural steroid injection. Transforaminal injections can cause the radicular artery to get blocked or damaged. One of the first cases published from Mayo Clinic actually was, and I wrote a letter as a response to that publication in an Ezra journal. It was physicians trying to do a transforaminal at the level of surgical radiculopathy, which was at about L3 level. They did multiple tries at L3 level on the left side, could not get in. So they said, okay, well, let's go one level higher. So they went to L2, multiple trials again, and then they injected, no arterial spread. So they documented that, they published it, that even without arterial spread, you can have patient paralyzed. Not knowing that this sharp needle that was used during the procedure, and the Quincke needles, for those who know, are called diamond tip needles, which means they are very sharp and the edges are almost the same as a scalpel. It can definitely cut an artery or a nerve if you are trying multiple times. So the Quincke needle most likely cut the radicular artery at L3 or even L2. And after that, when they did this contrast injection, it did not really show any intra-arterial spread. But by that time, the artery was probably already cut, and the patient, and it could not be repaired, I guess, and the patient had paraplegia because of that. So it was not the procedure that was documented afterwards. The documentation was fine. Everything looked okay on the contrast injection, but patient still got paralyzed, not because it was intra-arterial injection, but because the artery was already damaged from multiple tries. Something to remember very importantly in the cervical spine as well. And many cases, not many, but at least some cases have been documented to cause complications such as quadriplegia when a steroid is injected in the radicular artery in the cervical level. At the site of injection, abscess, hematoma can happen. Recently, I came across, everyone might have heard about the procedure called ablation of the basivertebral nerve. I have not seen much publication about what happens to the inside of the vertebral body, the cancellous part, and whether it develops any weakness of that part, what happens to the arterial supply to the end plates, and patient ended up with multiple abscesses and even discitis at 2 levels because of that. Hematoma can happen. These are known complications. The thing is, you have to be able to recognize them in time. If the patient complains of something, always investigate. Osteoporosis, diabetes, and even Cushing syndrome can happen with excessive steroids. And the person who gives the steroid is responsible to monitor the bone density of the patient or even the blood sugar levels of the patient. Giving excessive amount of steroid and then saying that, well, it is not my job to monitor the patient's bone density, it is the job of the patient's primary care physician, is not going to help much in the court of law. Spinal cord damage, like I mentioned, can also happen. So before you inject anything, always listen to the patient. Sedating a patient very heavily. And those of you who are doing the procedures under sedation all the time should remember this, that a sedated patient will hardly ever complain of any procedure complications. So if you get some paresthesia in a patient when you touch a nerve root, if that patient is sedated, they may not even respond to that, and you might be injecting in the nerve root itself, causing more damage to the nerve root. So always, in my opinion, for interventional pain, unless the patient requires sedation heavily for things such as creating a pocket for a stimulator or pump, or passing the catheter or a stimulator lead under the skin, making a tunnel, that would require some sedation, which also can be taken care of with light sedation and local anesthetic if you know exactly how to do it. For example, for intrathecal pumps, I almost always use spinal anesthesia. So patient is still awake. Does not mean I cannot damage the spinal cord, but with the help of proper fluoroscopic guidance, I can definitely make sure I'm not inside the spinal cord at that time. Radio frequency can cause nerve root damage, especially if you don't take any lateral views while doing radio frequency. Muscular weakness is something that many physicians don't pay attention to or not even aware of. But as you may know, during the motor testing for radio frequency needle placement, you see the twitching of the paraspinal muscles. And that is the nerve actually you are going to lyse. The medial branch and lateral branch at that time are very close to each other. So lysing the medial branch to make the facet joint insensate would also damage the lateral branch, which supplies the paraspinal muscles, making the paraspinal muscles very weak, and the patient's ability to stand erect will be reduced to a certain extent. The more levels you do, the weaker the patient can get. So up to 2 levels is acceptable, and the patient can regain. Unilateral is more advisable than bilateral, but doing 3 levels can weaken the muscles more than it can recover from, at least till the duration that the nerve, the medial branches, lateral branches can regenerate again. Disc procedures can lead to discitis, nerve root damage, spinal cord damage, all other organ damages. There has been a case of aortic damage during disc procedure, disc decompression, with multiple holes in the aorta that were caused by the decompressor going in and out of the aortic wall, and the patient ending up with anoxic brain damage because of that. So taking precautions before, meaning antibiotics properly, nerve root damage, monitoring the patient properly, keeping them as awake as you can, and the spinal cord damage and other organ damages can be reduced by proper technique, proper imaging, and monitoring the patient. Lead migration infection are very well known for spinal cord stimulator. It is important to recognize why your stimulator is not working. The first thing you want to know is take the patient's history, like what happened when they stopped working, And if the patient says, well, I fell down and it stopped working. I had a patient who belonged to a very dangerous gang here in the southern part of the state, who came back and was quite angry at one of my colleagues who put the stimulator in, and said, my colleague says he was afraid to even go in the room. So I go in the room and he tells me he was in a bar and had a barroom fight, and some of the people there lifted him and threw him on the floor. And no question, the lead moved, and now it is not working. So it had to be revised, but it was revised properly, and stimulation gave enough pain relief afterwards. So it is important to recognize and get a good history before doing something else. Intrathecal pumps are known to be injected with wrong medications, misdirected refills where actually the medication ends up in the pocket where the pump is and not in the pump itself. So the patient not only gets the medication from the pocket, which is unregulated, but does not have anything in the pump itself that goes in the CSF. And then there is a collateral damage. And some of you might have even seen this movie, Collateral Damage. People allergic to any drugs, there are positional issues, you put the patient prone, and if you see it from the patient's side of view, patient is looking down, doesn't have any idea of what is going on behind their back. So be very careful what you say in the procedure room. Do not make any comments that are not quite complimentary to the patient. For example, my staff was instructed not to use certain words like oops, never use that, or oh my God, or something like that. That is going to startle the patient. It might just be that the nurse just dropped a syringe on the floor. And if they say oops, patient will probably think that something wrong happened during the procedure. So certain words like that should not be allowed. Be always very careful about what you say around an awake patient. But that is not a reason to sedate the patient, of course. It is just that you need to learn how to be careful, and you have to pay respect to the patient who is awake, lying prone, not able to see what is going on behind their back. And it is your duty to keep informed the patient on what is going on, what you are doing, and keep them calm and keep them in conversation. Tell them what is going on, what you are doing, what step of the procedure you are at, and what they can feel, and what they should be telling you if they feel something different. So for the interventional procedures, what is important to document? Symptoms is what the patient tells you. Pain is a symptom. Compare that to tenderness, which is a sign. That is what you get when you examine the patient. You get the onset of the symptom, how the disease progressed, what happened, and then what you find in the signs is what you find during the examination of the patient. It may or may not match what the patient tells you. Patient tells you my leg feels numb. They may not know that it is actually not numbness in a particular dermatome, and they cannot describe to you and say, well, looks like my L5 has lack of sensation. They are not going to tell you that. So you are going to document, is it L5 or L4 or L3? And what you find should match what patient has. For example, if you are doing a straight leg raising test, it is supposed to set the sciatic nerve component, L5 and S1 and S2. If the patient has L2 radicular pain and you say patient has positive SLR, those two things don't match. Always ask yourself what you are documenting, whether it makes sense or not. Weakness might be due to patient's inability to do something because of pain. It is not actual weakness. Patient may have motor power of 5 out of 5, but they might say, well, I feel weak in my legs because I cannot do certain things. I cannot walk so much. It may not be objective weakness, but it might be subjective weakness. So a detailed MSK exam, musculoskeletal, as well as neurological exam is very important for us as pain physicians or interventional pain physicians. To document the past treatments, you want to document what types of treatments the patient had and what was the duration of the treatment. Patient took some NSAID. That is not something what you want to document. If your patient took ibuprofen, you can say patient took 600 milligrams of ibuprofen 3 times a day for 8 weeks. That is more specific and would tell you more in the future or someone else in the future about what was tried and what failed. Doing physical therapy for one session means nothing. So if you just say patient tried physical therapy, tried medications, that doesn't really say anything specific about what was tried in the past. So types of treatments, the duration tried, outcome, and what was actually, if there was a side effect or not, you want to document that as well. Dosage, type of drug, physical therapy, any other complementary treatments should all be documented. Radiological studies, the reports of MRI, CT, myelogram, X-ray, and their dates when they were obtained. Something that is 5 years old should not make you treat the patient now because you don't know what is going on at present. If the patient had radicular pain 2 years ago and you did epidural steroid, patient got pain-free, 2 years later comes back and says, I'm having this pain, don't always assume that that is because the epidural, quote unquote, wore off. The epidural was gone long time back. That was not what brought the patient back. Something new must have happened. It is your duty to find out what happened and why is the patient having pain again. And to do that, you do a proper history, proper physical exam, maybe repeat the MRI or CT scan. Are there any relative contraindications to the procedure? If you are injecting the steroid, ask yourself, does the patient have any diabetes? Is the patient an older woman with osteoporosis already set in? Should I be using the standard dose of 80 milligram methylprednisolone in everyone? Can I reduce the dose? Is the patient getting any steroids from someone else as well? Is the orthopedic surgeon doing shoulder injections, knee injections? And combine all that together. So that would be a relative contraindication to give more steroid to the patient.
Dr. Vikram, we would try to wrap it up soon now because I think
yeah,
it
is a long subject. I'm sorry.
I totally agree, sir.
Yeah.
But yeah, I'm just
okay. Let's speed up a little bit more.
Yes.
For the systemic disease, you want to document if they are controlled or not, and what is your procedural plan, specific type, level, and laterality, and that cannot be emphasized enough. Specific requirements such as imaging guidance, sedation, site of care where you are going to do it. Common pitfalls for documentation are many. Don't always take the patient's word for it or patient's family report or the previous doctor's notes unless you confirm that. Always focus on the problem, not the EMR and how they guide for your billing company. Past treatments, confirm what the patient tells you and match that with the data that you have, like the imaging report, physical therapy report, radiological studies. The radiologist report has more legal standing than your interpretation. So always remember that. If you find something the radiologist missed, have them put an addendum. Any relevant contraindications, systemic disease, and then the procedural plan. What the patient needs rather than what you think is appropriate is what is important. The EMR documentation with preformed templates can be a big hazard. If you just copy and paste your prior notes, that may not be true all the time. Always be very careful, modify for each visit. Don't rely on the level of billing when you do it. If you are done with a certain level of review of system or exam, don't stop there. Always do the relevant exam first. You have to co-sign your nurse practitioner or PA's note, but don't co-sign without fully reading it. Make sure that that is exactly what you would write in your notes. Pre-made templates sometimes are a big drawback. Always read a printed copy of your whole note by yourself. Let's see. This is more for the US people. More important to remember, always know your subject, not only the theoretical part, but the practical aspect. Document what makes sense. Get proper training and certification that might help you in the court of law. Always be ready to justify anything and everything you plan to do on a patient. Think of all the consequences of your treatments. Just because you know how to do it doesn't mean that is what the patient needs. What are the possible ramifications in the future? Steroid access, for example, certain drugs, patient position, radio frequency, neurolysis. Any applicable guidelines and policies need to be followed. So the failures are because you fail to recognize. As you can see in the images here, that is a plane going down actually, and you see the sky up, which is the blue part, and the ground down. So this is a plane going down. If you don't recognize that, you are going to crash very soon. That is what it should look like. Keep the blue up. Lack of knowledge sometimes makes you do wrong things. First mistake, you don't learn from it. Denial, always learn from your mistakes. Denial is not going to help. Ignoring the warning signs, failure to manage them properly, they're all very, very important. And we'll skip the real life examples now.
I agree with it, sir. Really, I mean, we have some questions.
But let's go with some questions now. Yeah.
But sincerely, I mean, great talk. Thanks a lot. I mean, you really.
It was very, very, very good, Vikram. I think, and as you said,
it was a little bit lengthy, and I think it's a long subject covered in a short time.
Yes, agree. And I think,
to be truthful, I would have thought that there's not so much to talk about it. Frankly speaking, there's so much lessons from each and every side which you have shared. Sadik, you want to add something right now, or should I go to the questions?
Just go ahead with the questions. I was saying he's given real life examples which actually made a lot of sense, and especially covered every aspect of interventional pain management, what could go wrong. And I think it just made us quite aware of what
exactly
that somebody could come across in their day-to-day life. And I think it was very, very practical. So thank you so much, Vikram. That was fantastic.
Thank you.
My takeaway message for today for myself is it doesn't matter what I know, who I am, what my expertise or what my experience is, but what matters and most important is what I document. That's so right. I guess what you said, you document what you see, document what you do, and always be vigilant. So this is what is my take-home message for myself. I would jump to the first question, which is being raised by Mr. Tayyab, Dr. Tayyab. Well, since you mentioned about your experience of experience and expertise about telling exactly whether the pain is from SI joint by just observing the gait. So he's asked you, can you tell how would you actually differentiate by just observing? Share your experience on comparing SI joint pain, facet joint pain, and nerve root pain. How would you just tell that by seeing the patient without examining?
Right. So the history and physical are very important. Patient comes to me and I have this pain in my back. Okay, that's what the patient will tell you. So my first question would be, how did the pain start? And they would say, well, I was shoveling the snow in winter, and then there was ice underneath and I slipped and fell on my buttocks. And that's when the pain started. Immediately I'll start thinking, okay, the patient fell down. Most likely, what happens when the patient falls down on the buttocks? The pelvis stops and the spine continues to fall for a couple of more millimeters. Disruption at the SI joint, very likely the SI joint. Then I would say, okay, what are the aggravating and relieving factors? What makes it worse? What makes it better? And then I would say, well, how does the pain radiate? This is just part of the history that we are all supposed to see. And ask the patient. Okay, patient says, well, most of the time I don't have much pain, but when I'm sitting for some time, then I get up, I start having this pain in my back. And then when I straighten up, it is actually worse in the morning before I get out of the bed, or when I get out of the bed, and then it gets gradually better. In the evening, it gets worse. So, and the character of the pain, well, it is more dull and achy. I don't feel like shooting pain, tingling, or numbness. It's all not there. That will make me feel like, okay, more likely the pain is coming from the SI joint. And then I would say, okay, does it hurt more when you go up the stairs or down the stairs? And they would say, well, if I go down the stairs, I'm fine. But if I go up the stairs, my pain is worse. So forward flexion going up the stairs is increasing the pain. But coming down, you want to compare the patient's daily day-to-day life activities with the aggravating factors. If you just tell them, well, is your pain worse with extension or flexion? They may not even understand properly. So ask them, is there pain worse when you are doing your dishes and leaning forward or brushing your teeth? Or is it worse when you are stretching your back, going backwards? Something similar they can relate to. So combine that with their gait and you say, okay, when you walk, which side do you favor? Is that the side you have this pain on? So all these things combined, I won't even have to examine the patient. And then I examine the patient, I would say, okay, why don't you walk? That is the observation. And as we learn in the medical school, observation, palpation, auscultation, all are part of the exam. I would palpate the SI joint. Oh, that is where the tenderness is. Let me check the provocative testing. Does the patient have that? Is there anything else going on? Is the patient having any hip pain? Does the patient have any spine pain? So all that combined would make me think, well, this is more likely SI joint pain. And then if I do the injection with diagnostic local anesthetic or with steroid combined, and the patient says after the exam, oh, that was excellent. I had almost no pain after the exam, after the injection for about 6 to 8 hours. Then the pain came back, and then the steroid kicks in after 48, 24 hours, and then the pain start getting better again. So that is how I would diagnose SI joint patients.
Yeah. So we have next question. The question is from Dr. Jawad Malik. I know Jawad very well. He's from the UK. He says, majority of the procedures are performed by me are done in a stepwise manner and in a standardized way. All the documentation is also documented in a step-by-step and a standardized way. Does this hold value in litigation? Okay. And standardized templates are used for each procedure. These are only changed if anything is done differently in certain cases. Does that actually carry any weightage, you think? I know you told us that if you have templates, sometimes that can lead to an autopilot mode and that can lead to an error.
Right.
But if you're doing a certain procedure in a specific way, for example, anything about clavicle, I'm doing any block, I'm going for dexamethasone. I do not use depomedrone for anything about clavicle. That's my standard that's my standard kind of standard of care. So do you think having that kind of standard of care and having a standardized format of documenting things makes a difference when it comes to the litigation? That's basically the question that is asked.
Well, it might be one of the defenses you can use that, these are the precautions I take. So you don't want to use it for a standard thing like, okay, I do this for all my back pain patients. That is not going to work. So if someone comes to me and say, okay, their musculature in the back is weak, and they actually had just discogenic pain, and you did radio frequency for the facet joints. If I was the plaintiff's lawyer, the first thing I would ask is, well, doctor, you are applying the same treatment for everyone with back pain. How many causes of back pain do you know, doctor? And he would say, well, the back pain can be from the disc, from this and that and that. Okay, so why do you apply everything to everyone? Does everyone have everything that is wrong? And that will put the doubt in jury's mind. All you need is one doubt in the jury's mind and say, this doctor doesn't know what he's doing.
Sure.
So the standardized templates will work up to a certain extent as long as you can say that these are justified.
Yes. Okay. Got you. So I think it's good to have a standardized way of doing things just for your own safety and to improve the safety and accuracy. For example, if I'm doing any procedure in the neck like stellate ganglion or cervical sympathetic block, I will never do that with X-ray because my standard of treatment is using ultrasound. So I gather what you say. Having a standardized will help in terms of accuracy and safety from patient point of view and from your own point of view. But when it comes to the court, I think you have to tailor make the treatment based on the patient. So
exactly. So by the same token, we all write down the entry point was prepped and draped in customary manner.
Yeah.
And if you write that every time, and if the patient gets infection, the witnesses for the plaintiff would be the nurses that are observing you.
Sure.
And that is your defense. Like they would ask the nurse, okay, how does the doctor do this? Well, he uses the betadine swabs 3 times and then he puts sterile drape on. Okay, so that is your standard of care. That is your template. That works. Yes. But on the other hand, if you say something like something that has not been standardized in your care, then that is something unique that you want to document a little bit more elaboratively. That, okay, I obtained a lateral view or an oblique view at this angle and I was able to visualize the Scotty dog or whatever. Now that is going to be specialized for certain procedure. And you don't want to follow the same thing like AP and lateral views are obtained. Okay, what if you did a procedure that requires oblique view?
True. Okay.
Thank you, Vikram sir. I have a personal question. My question now. I mean, the other 2 questions I noticed were primarily related to the procedure. So we would not go into the procedure related questions. I have a very valid question, I feel, that we do a lot. I mean, we do a lot of medications, even steroids. A lot of off-label use of medications is done in pain medication, right? Pain management. Some people even question orthopedicians, spine surgeons that you're doing epidural, it is not FDA approved, right?
Right.
So how do you defend that sort of a question? I mean, you have done everything which is done, which has been done by your teachers, by your professors, by everybody, but it's not FDA approved, right? And a patient who can come back to you always and said, you never told me that this is FDA approved or not approved. So how do you defend yourself with that question?
Because FDA approval does not really say that that is the only thing you can use it for.
Right.
It is a guideline.
Okay.
FDA tells you that using, for example, lidoderm patch, when it came out with a patent, it can be used for post-herpetic neuralgia.
Mm-hmm.
I had a patient who had supraorbital neuralgia from an injury, and it would not get approved because, well, that's not what it's approved for. And I had to compare that this neuralgia from herpes zoster is not a whole lot different than this traumatic neuralgia the patient has. And that is why it was being used for that. So it is still a neuralgia, but FDA requires specific data and request. If you are getting an approval for spinal cord stimulator just for CRPS, and if you use it for post-laminectomy syndrome, it is still valid because evidence-based literature supports that.
Sure.
But that particular company may not have spent enough money to get approval in studies for other indications.
Okay.
So they might just have gotten an indication for CRPS and they say, okay, we are good to go, let's start. So as a physician, you can apply any known treatment to anything you want. The thing is, are you prepared to face the consequences? Are you aware of what wrong can happen? You are supposed to tell the patient, of course, that this is not FDA approved, but it is evidence-based, and there is a lot of literature to support the use of that. And that is what I'm going to do for you, and that is going to help your pain. If you don't want me to do it, I can suggest something else, and you can definitely suggest, alternative medication or physical therapy, or just wait for time. So that is, FDA approval does not bind you to use the drug. Like, for example, gabapentin is not FDA approved for what we use it for every day.
True.
Like neuropathic pain.
Same thing with
That's
steroids
correct.
as well. I think, there's also quite a lot of gray area, but yeah, there are so many things that we use in chronic pain, which is actually there are so many off-license indications for medication. Okay, we're going to just take the last question now, Vikram, before
Sure.
we conclude. So the question is from Ajit from the UK. He says, what is your opinion about standardized consent form where you can tick box the complications? Is this legally acceptable? So, we have consent forms. I think in the UK, we still not everything on electronic records. We have a printed version of consent form where we basically tick box like infection, bleeding, bruising, failure. So
Right.
do you think, does that actually carry any weightage in the medical legal kind of, world?
Actually, that was part of another slide that I had in a patient example.
Right.
The consent actually is required by law. If you are doing something to a patient, they have to consent to it. Otherwise, it is considered to be an offense.
Yes.
For example, in anesthesia board examination, we had one question. The patient comes to the operating room. The surgeon is not even there yet. And you start an IV and the surgeon is involved in an accident outside the hospital. He cannot make it. That starting an IV is considered to be an assault. Because you started an IV without indication. You did not make sure that the surgery is going to happen. That IV was meant for surgical anesthesia, and you started that without proper indication. So that does not really fly. So the consent is required by law. Does it protect you in the court of law? Not really, because a patient in pain is considered to be patient under duress. And anything the patient signs under duress cannot be 100% considered as legal. So you can point a gun to someone's face and say, I'm going to take all your money from the bank account. They might sign the money off to you. That does not make it legal because they just signed it, because they were under duress at that time. So that is a tricky business. If you get the consent, you are better off. If you don't get the consent, there is no defense. But if you do get the consent, it doesn't protect you all the time.
Does a tick box thing carries any weightage, or do you think it's a good way to have aid memoir where you don't miss out on telling any complications to the patient, but does that carry any medical legal weightage? That's the question we
If
have.
something really bad happens, it may not. So the patient would be asked some simple question. Did the doctor tell you that you might get paralyzed? He might have told me, well, there's a tick box here that you tick mark and sign. Well, I was in so much pain, I did not even read what I was signing.
Okay, okay, right.
So
Got you.
did the doctor explain this to you? Well, he never talked to me about it. He just gave me this form with all the tick marks and I just signed it.
True.
I guess at that point, we might have to defend by saying that these are the steps we took to make sure that this complication does not happen. Am I right, sir?
My,
Right.
my,
And you can also say the requirement of a witness for that same consent form.
sure.
Every consent form has to be witnessed. It cannot be just you and the patient. It has to be a third person who can stand up and say, yes, the doctor did discuss this
Sure.
beforehand.
I think from my kind of years of practice in the UK, Vikram, I know you work in the US. In the UK, as we say, consent form signing has no value unless you have followed a process. So consent is a process rather than one-off event where
Right.
you want the consent process starts when the first time you see the patient in the clinic. So that includes when you actually tell them about the procedure. So you have to document in your notes that you have told them about the possible complication. That's number one event. Number two event is you giving them some written information in the form of information leaflet saying, I've handed this over so the patient can read it at home and reflect on that particular procedure and the complications to make an informed choice. And that's number two. And then number three is on the day when they're coming for the procedure is when they're forming the consent, when they're signing the consent form, you also again reiterating the same message that they gave them in the clinic. So I think if you follow the whole process, that's when the consent form carries a weightage. Otherwise, if you signing the tick boxed consent form carries no weightage unless you've actually told the patient multiple times and documented in your notes multiple times. So that's how the medical legal side of UK are considered in terms of the consent, and that's what the General Medical Council in the UK recommends. But I think you're right. If somebody's under distress, then the consent has no value, and you got to.
Unless you discuss that with the patient in detail, and there is a witness to it.
Sure. So that's great. Thank you so much, Vikram. I really appreciate your time, and it was a fantastic pain talk. You gave a really thorough understanding and a good insight to this subject. And it's a very complex subject, but you made it very kind of very understandable, and also made it quite enjoyable because you told us all the real life scenarios in your 30 plus years of your career in pain management. So we really appreciate. Thank you, everyone. I will put the recording on the YouTube channel of Pain Talk. So please access that later and have a great evening. Thank you so much, Amit, for moderating. And I'll see you around.
It was an honor.
We'll meet in the future,
and then, thank you.
either in US or in Budapest. Take care.
Thank you.
Take care. Bye.
August in Budapest.
Bye-bye, sir. Take care.
Take care. Bye.
Bye.